Good morning. Welcome to discussion of the Medicare's Trustees Report, which was released by the trustees of the Medicare program yesterday at 4 in the afternoon. My name is Joe Antos. I'm with the American Enterprise Institute, and we're delighted to be able to bring this discussion to you. More than 65 million Americans depend on Medicare to finance their health benefits. A longstanding concern is whether the program is fiscally sustainable. In other words, can Medicare maintain the level of services that the public has come to expect? The annual report from Medicare's trustees provides important insights into the factors affecting Medicare's financing and the program's future challenges. This isn't the first time we have had this discussion. We seem to have it on a regular basis about every year. And the fact is that there are concerns every year about the fiscal future of the Medicare program. The good news this year is that the trustees say that Medicare will be gets another 5 years before the trust fund, the Part A trust fund, becomes insufficient to cover all the costs in that year. But that's the good news. The bad news is after that point, there could be a problem unless something changes. So that's the ongoing policy problem for the Medicare program. And the ongoing challenge that I think policymakers and senior citizens and people who will become senior citizens face as they look toward the future. I'm delighted to introduce Paul Spitalnic, Chief Actuary of the Centers for Medicare and Medicaid Services. Paul is an old hand at this. The trustees report is maybe the most publicly well-known report that Paul has is not only his name on, but also his trustee staff works. It contributes greatly to this report every year. But in addition to the trustees report, the Office of the Actuary produces a vast amount of analyses to support the administration's policy initiatives and to better understand where Medicare financing is likely to be going in the near and more distant future. So let me ask Paul to say a few words, and let's put the show on the road.
Good morning. Thanks, Joe. Thanks everybody for joining. I'm pretty sure you just called me old, and I will do my best to move past that. I think I'm going to actually agree with you based on the way my body reacts to many things these days. It is my pleasure to talk about the 2024 Trustees Report. Joe noted this was released yesterday by the Board of Trustees. Here's just the outline of what I'm going to talk about, where the program is today, how it has evolved over time, the key results from this report, some of the key modeling differences, which this year was probably a little bit less so than in previous years. Go over some of the detailed results, and I always try to add something that provides a little more context in a little different way that will hopefully people will find a little bit interesting. So this is how the program is organized, and for those that have been through this or as old hands like Joe and myself are very well familiar. There are two trust funds that support the Medicare program. The hospital insurance, HI, is the trust fund that provides Part A services. These are mostly services that are provided in an institutional-like settings, inpatient care, skilled nursing, home health, following an institutional stay, or hospice care. This is the program that gets the most attention when the trustees report gets released because this is the one that changes um, every so often in terms of the year of its depletion. And that is because the funding for the HI program is different than the supplementary medical insurance. The funding is similar to how the OASDI program is funded. It is funded predominantly based on payroll taxes. 1.45% paid for by both employees and employers, or 2.9% for those that are self-employed. There is an additional 0.9% for high income earners. Those amounts aren't indexed, so that actually picks up more income each and every year. And there's also some taxation on some Social Security benefits that are deposited into the HI trust fund. This is the one that has a depletion date, just like the OSDI one. This is the one that gets the most attention after the trustees report has been released. But you know, even greater in terms of federal spending is the supplementary medical insurance programs. This is both the Part B, as in boy, and the Part D, as in David, programs. Part B provides the complement to most of the Part A services. So this is services that are provided in non-institutional settings, things like physician services, outpatient, home health care for those that are not following an institutional care setting, diagnostic tests, medical equipment, ambulance, and physician administered drugs. Part B is funded through beneficiary premiums and then a matching general revenue contribution by the government. This program is financed annually, so there is not the long-standing um, solvency issue with respect to the Part B program. But as this program grows, it provides additional strains on both the beneficiaries that are paying the premium and on the general situation of the federal government. So just a growing share of federal spending. And finally, Part D is prescription drug program. This is also an optional program that people can choose to participate and get their prescription drug coverage. This is also funded on an annual basis. It is set up a little bit differently than the Part B program, but generally the revenue is similarly constructed, beneficiary premiums, and mostly funded through federal contributions as well. There's some other sources as well. One thing you'll notice at the bottom is that the expenditures, um, you'll notice that the Part A program is 403 billion. The Parts B and Part D programs are in excess of 600 billion. If you add those together, we're now into the trillion, which is a large number even by government standards. Um, but also just that distribution between Part A and the HI trust fund and the SMI trust fund. You can see it is largely Medicare is now largely funded through the supplementary medical insurance program, and we'll see a little bit more about that as we walk through the presentation. As the trustees project 75 years into the future, I always think it's important to provide a little bit of context. This is a couple of snapshots of how the program has changed over time. And you can see back in 1983, 40 years ago, not quite 75 years ago, we can't go back that far in Medicare just yet. But you can see that the program was predominantly an inpatient program. And some other physician is clearly noticeable here, but that's the extent of that pie. If you kind of see how it's evolved, and now you look at 2023, now most of the services that are provided through Medicare are actually funded through the Medicare Plus Choice, managed care programs, Medicare Advantage. We'll spend a little more time talking about that in a moment, but we're not quite to half, but it's getting close to being provided through Medicare Advantage organizations. Part D did not exist back in 2003, and that's a clear, a significant portion of payments as well. But to me, the broader context here is that there is just a lot of uncertainty in terms of how these program this program will evolve over time. And as we're making these forecasts, as I said, they go 75 years into the future. There's a large degree of uncertainty. There's a large degree of legislative action that will affect these, the trajectory of this program. But what the trustees report does and intends to do is to provide a snapshot as to what the expectations are for the current law benefits are going to evolve, what the financial effects are of the current law benefits over time. And that's what the trustees are representing in their reports. There's some notes and caveats around some aspects of current law might be challenging to adhere to, and I'll talk a little bit about those later on in the presentation as well. What gets the attention is the depletion date of the HI Trust Fund, and I'll spend a little more time talking about this throughout the presentation. But the key takeaway is that the trust fund is in much better shape this year than it was projected to be in last year's report. 5 years is a big change in 1 year of the report, especially when there was no major legislation truly affecting the programs. So what happened? Why are we, why was the depletion date pushed back 5 years? Two things, lower expenditures and higher income. That's a good way to improve the financial situation of anything. Spend less, earn more. Expenditures were lower by, just looking at this 10-year period, compared to last year's report by 4.7%. The largest change here was with respect to that Medicare Advantage program. There was a policy that was announced after the release of the 2023 reports that was going to phase in a change to the Medicare Advantage payments. There was a technical issue with how the rates were established for Medicare Advantage that was going to be phased in over a 3-year period. Being that it was announced after the release of last year's reports, it wasn't reflected. It is reflected here, and that does have a pretty significant effect in reducing expenditures over the next decade. And similarly, on the income side, the economy is doing great. In terms of payroll, income, and payroll taxes coming into the HI Trust Fund, the amounts are just much greater than what was expected, a very short period of time ago. I'll spend a little more time talking about this at the end of the presentation. But basically, fewer expenditures, more income, significant improvement in the trust fund status. So talk a little bit about the key modeling changes. As Joe alluded to, I've been doing this a while. And for the last several years, most of the discussion has been around the COVID-19 pandemic and the effects on spending. Now that we're in the post-public health emergency period, we're observing that that Medicare fee-for-service per capita spending has stabilized, that the trends are becoming much more predictable and more in line with what we would have otherwise expect year to year. And so as a result, the trustees are placing a greater reliance on this more recent experience that has demonstrated a fair amount of stability to it. There are still some remaining fee-for-service adjustments that are being reflected in the estimates. And these are largely consistent with what the expectations were in previous years, but the fact that these are the only ones remaining is in and of itself noteworthy. But the three that are still affecting future trends are that with all the excess mortality over the last several years, there's a morbidity improvement, that those that have survived have tended to be healthier than what they were previously projected to be. So we expect that those effects will last for several years, basically, as as we get back to a more standard morbidity levels. Those lower level of spendings will erode over time. Um, Second is the sending of the 3-day inpatient stay requirement to receive SNF services. That was just a byproduct of the public health emergency, and so we're expecting the unwinding of those effects to affect trends over the next couple of years. Um, and lastly, the home health spending is just dramatically lower than what it was expected to be prior to the pandemic. We think that some of this has to do with some staffing shortages that we expect will correct itself over time, but these levels are much lower than what they were expected before the pandemic. Even after the staffing shortages are expected to be worked through, spending is still lower than what we would expect it to be through the pandemic, from prior to the pandemic, but at somewhat higher levels than what is currently being experienced. So just to look at some of the big picture comparison on starting with the HI trust fund. You can see the income side clearly on the top. Amount of income that was expected in the various reports compared to what was expected last year, just higher. Higher from 2023, through 2027. You can see an extra 40 billion, not quite 2%, but pretty significant on that side. And on the spending side, you can see that actually pretty close on 2023 in last year's report. 2024, you can start to see the effect of that MA policy in particular. But for 25, 26, 27, you can really see that some of those policy effects, the most noteworthy, the Medicare Advantage policy, is significantly slowing the increases in spending in this year's report as compared to last year's report. I will note that there are some other services on the HI side that are lower than what we were expected last year. Those include inpatients somewhat, and the home health a little bit more. But clearly that big driver certainly in the 25 and 20 through 27 period, that's more so the MA change in policy. Looking at a similar analysis on the Part B side, there's just less action here. The income is just mostly a timing, and you would expect the income to align with expenditures over time because the financing is reestablished each and every year. And looking at the expenditures, you can see that there are some pretty modest, not quite insignificant, but modest reductions in expenditure projections over the next several years. Looking at a picture, pictures are always nice. You could see the trust fund, the HI trust fund ratio. This is as a share of expenditures, assets at the beginning of the year compared to the expected expenditures for that year. You can see that this has bounced around a fair amount over time. You can see in the late 90s, there was a pretty rapid acceleration as costs increased pretty substantially. And then, sorry, that went the opposite as cost growth slowed substantially relative to the increases we saw in the late 90s and the robust economy in the late 90s. And it flips around as we start to see the retirement of the baby boomers. You can see that in the 2010 to the 2020 period. That slope was actually slower than what it otherwise would have been because the cost growth considerably slowed during those years. And then in terms of the projection, you can see we're projecting that there's going to be a slight increase. So there's a few years of surplus. We've had a few years of surplus over the last several years. We expect that to continue through 2029. And then deficits are expected to return for most of the projected period. And the depletion date is now 2036 as compared to 2031 last year. Um, this is the overall financing of the program. This hasn't changed much directly. You can see the evolution of the program if you kind of think back to those pie charts I presented earlier in the presentation. You can see back in the 80s, this was mostly funded through the purple, the tax on the payroll taxes, and only a small amount was funded through the general revenue transfers, which is mostly the Part B program, together with the premiums in the yellow there. You can see over time the Part B program has grown quite considerably, and now you can see that those, that yellow plus the blue, is far greater than what the purple and, and the red, crimson, the income that's coming into the HI trust fund, and that's just exactly aligning with those expenditure growth that we alluded to earlier. So these are the different components of the financing of the program. The one that I'll note in particular is just on the top, the deficit. That is what is not funded through current law, and that represents the amount of HI spending that is not funded through existing payroll taxes. And we'll talk a little bit more about that in a moment. So in addition to talking about depletion dates on the HI trust fund, we also talk about this actuarial balance. This is how much additional revenue will be required to put the trust fund into balance. And so this is just looking at the present value of income less costs. And a way to think about this is how much does that 2.9%, remember, said that the financing is 1.45 from both employees and employers, so that's 2.9%. How much would that need to increase in order to have the HI program fully funded under current law? And in the 2024 report, it is 0.35%. So if the 2.9% were to increase to 3.25%, the HI program would be adequately financed throughout the entire 75-year program under current law. And so what does that look like a little bit in picture form? This is comparing the income rates and the cost rates. The bottom lines are the income rates. You can see that there's not much of a difference this year to last year in terms of the income rate. Again, this is in comparison to taxable payroll. So you don't get the fact that taxable payroll is significantly higher this year than it was last year, because in this chart, it's just looking at it as a rate. As compared to, you see on the cost rates, what's on top, you can see that the solid black line on the top line is much lower than the dotted line. Not all of that is due to lower expenditures. A fair amount of that is due to the fact that we've got a bigger denominator. We've got more taxable payroll, and so that's pushing down that cost rate line. I mentioned earlier that there's certain aspects of current law that are maybe challenging to adhere to. Certain things on the physician side in particular, with respect to certain of their payment rate updates. They're specified each year into law, negative for 2025, roughly 0.75 or even lower thereafter, which is obviously significantly lower than expected rates of inflation. And so there's just concerns with how well current law will keep up with physician payments. Similarly, on HI services, most of these services are updated with a payment rate update, but then we subtract off economy-wide productivity. And it has, historically, providers have not been able to keep up with, healthcare providers have not been able to keep up with economy-wide productivity. It's been much lower than those levels. So where economy-wide productivity might be something like 1%, healthcare productivity has typically been in the 0.4% range. And so those, if we're saying there's a gap in terms of provider cost by this 0.6%, that doesn't sound like a lot until you say, what is the effect of that over a 75-year period? And that's where you get to what cost would look like under a 70, to the extent that certain aspects of current law are not adhered to. And you can see here, and similarly on if we were doing a similar chart on Part B, just this potential for significant additional costs to the extent that certain elements of current law are not fully adhered to. And the trustees do discuss this illustrative alternative, throughout their report. The Office of the Actuary has a memorandum on our website that goes into this in more detail on the website each year, so see more details about that. So that's mostly on the HI side. On the SMI side, there's not a lot in the terms of the big picture here. You can see that on Part B, uh, the share of GDP has gone up somewhat on the Part B side. Um, there's not a lot happening there in terms of there's some additional services being provided, but GDP has also changed somewhat significantly. There's actually a peculiar pattern in GDP relative to last year where it starts off much higher because of just the additional economic outlook, but with certain changes in some of the demographic assumptions, most notably, there was a reduction in the fertility rate assumption in this year's report compared to last year's report. And that actually has a pretty significant effect as you look well into the future in terms of GDP levels. And so that's one reason we're seeing that increase in that out year Part B GDP is because GDP is just lower in those significantly distant years. Part D has even more going on, but doesn't, the story itself doesn't change all that much. There's periods of faster growth, slower growth, higher GDP and slower GDP. And depending on how you look at it, there's not a lot going on. But if you look at any individual period, there's a fair amount. Another thing that gets a fair amount of attention is just what are the expectations for premiums on the Part B side. Again, there was not a lot happening that was different than expected in the short run on Part B. And so the expectation for the 2025 Part B premium is consistent with what it was last year. This amount will be finalized and formalized in the fall of 2024. Part D has some IRA-related restrictions. So when the IRA came in and the Inflation Reduction Act had significant effects to the Part D program. Some of those effects were to significantly change the benefit design structure. And so some of those effects were adopted in 24, even more will be adopted in 25, including having an out-of-pocket limit for beneficiaries of just $2,000. And so there's some pretty significant changes there. But one of the things that the law did was restrict how much these average premiums could increase. And so the increases are actually known at this point in terms of the Part D average premium. So just wanted to take one opportunity to provide just a little bit of context around what's happening in particular for the HI program now. You can see what's here, for the 2018 through 2021 report. So 4 years in a row, we had the exact same depletion date of the HI trust fund, 2026, which is not very far from right now. And then over the last 3 years, we've seen a 10-year increase delay in that depletion. And so wanted to spend a little bit of time talking about why that was. What are the sources for this improvement in the trust fund status? Obviously, the pandemic hit in 2020, and so going to actually do some comparisons back to the report in 2020 compared to the 2024 report to see, okay, where are those differences actually coming from? And we'll start with the expenditure side. And on the expenditure side, you can see There was a little bit of timing issue around some of those expenditures in 2020. Use was actually a lot lower than expected, as people did not use services very much. But payments out to providers actually increased because of the accelerated advanced payments. And so there was a whole bunch of timing issues, but you can kind of see that basically spending has been lower than where we projected it to be in that 2020 report, in the 2024 report. Starting in 24, you can see that there's a noticeable bend down in the 2024 projections, and that's related in part due to the Medicare Advantage policy change, where those increases slowed significantly for 24 through 2026. So on net, looking at that 14-year period, or I guess 16-year period, we're looking at from 2020 to 2036, the point of current depletion in the HI trust fund. Spending is now projected to be 323 billion, or 3.23% lower than what it was projected to be in the 2020 report, effectively on a pre-pandemic basis. So that's pretty significant. There's some pretty significant reductions in spending there. Turning to income, though, this is where the big action is. You can see again in the history, things were a little bit lower in 2021, but you kind of bounce right back, and some of those increases, we just have faster growth here, and then also have faster growth projected for the next several years. And so what we have here is largely an income story. You can see that the differences in levels of income up nearly $1 trillion, 11.658%, higher than what was expected in the 2020 report. And so when we think of a 10-year difference in trust fund depletion date, yes, we have some pretty noteworthy expenditure reductions, but we also have just much more income coming into the program, a more robust economy, faster growth expected in the economy, and that is contributing to the improvement in the trust funds. I think that is all the material that I had prepared, so I'll turn it back over to you, Joe. If you want to start working on questions, I'd be happy to answer. We can have a discussion. Look forward to the talk.
Great. Thank you very much, Paul. That was excellent. Something that I should mention for the audience: if you have questions or comments, please send them either as an email to jack.rowing@aei.org or on Twitter using hashtag AskAEIHealth. And if you go to the AEI event page for this event, you'll see that information, so you don't have to jot it down quickly. A point, I guess, the first point I think I wanted to emphasize is important, I think, for everyone to keep in mind, which is that the trustees report is not a prediction of what will happen. It is a projection based on a bunch of assumptions, including the assumption that that largely current law will be in place essentially forever. But also based on recent trends. I can't define what recent actually means. I suspect Paul will have some comment on that, but not going back to 1965 means is what that means. But certainly, recent years tend to be weighted more heavily than more distant years for lots of sensible reasons. Medical technology obviously changes over time, but also economic conditions change for reasons that are really structural in nature. And so the world really isn't the same. And the United States isn't the same in terms of economic conditions as it was, say, 20 years ago, certainly 30 years ago. Things have changed vastly. So it makes sense to use more recent data or put more weight on recent data to do the projections. The big problem, of course, is that we did have COVID, and that kind of messes up the trends. But nonetheless, there are ways to work out those bumps. Fortunately, it looks like those were bumps. Those are not permanent changes. Although we probably should be concerned about possibly the next public health emergency, but that'll be in a future trustees report, maybe ideally in the distant future. In any event, I think the key element here is that the trustees, this report, they're not saying that this is what's going to happen. They're saying under certain assumptions, this is what could happen, but the assumptions will change, or the underlying economic conditions, the underlying usage of services, the underlying incidence of disease, all of those things are subject to modification as we go into the future and as we learn more about what the future actually holds for us.
So Joe, just to respond to
Yeah.
just a couple of the things you just noted there. So, um,
Mm, mm.
first, just on the notion of, here, these are the assumptions that are included in the report. And probably should have emphasized that the material that I was summarizing was based on the intermediate set of assumptions, the intermediate scenario that was included in the trustees report. The trustees report also includes both a high cost and a low cost estimate as well, and presents the expectations for what spending and financing and what the program would look like under alternative set of assumptions as well. So there is, it's not just a single point estimate. There are some, a couple of scenarios. There's a couple of sensitivity testing of specific assumptions that are included. There's a lot of chock full of good information in the trustees report for those that are interested in going through a 260 plus page document with any detail. Just on the notion of the recent experience and what does recent mean? Obviously, yes, we typically, when building off of a health forecast, you start with, okay, what was spending last year, last couple of years, last 2 or 3 or 5 years, and build the projection off of that. And as you correctly noted, then COVID happened, and COVID spending was drastically different in 2020 and 2021. Everything about the economy was drastically different in those years. And so when I said, in the presentation that, trustees are just putting a greater reliance on the more recent experience, what we've seen is that, so now once we start looking at the 2022 experience and building off the 2023 experience, what we're starting to see is that, well, 23 is growing compared to 2022 in a way that we had typically expected healthcare costs to grow in an annual period. And so that notion of this stability and predictability kind of returning to the program, and placing that greater emphasis on the more recent experience. That's what led us and the trustees confidence in order to provide that greater reliance. Whereas in prior reports, we were effectively comparing in some respects to, all right, what were we expecting based on trends through 2019? Because 2020 comes and kind of don't know what any of that means. But now that we've kind of gotten to that point where there is more stability and there is more kind of predictability, able to be associated with these emerging trends, there is that greater reliance. Not complete reliance, as I noted. There's a handful of services where there's other adjustments that are still being factored in. But there is this notion of we are getting to a degree of more predictability in the Medicare program and just health spending in general.
Yeah, I would use the word reliable. I think I would characterize this report, given what's happened, as more reliable in the sense that we seem to have come back to, as you say, more normal patterns of utilization. That doesn't mean, again, that doesn't necessarily mean that we won't get a surprise somewhere down the road, but short of something that is truly remarkable as COVID was. These numbers are I think, arguably something that we can rely on and think about a lot as we go into the next few years. One a point that I would want to emphasize that you actually made in your was it your fourth slide? It was the pie chart, and this is really relates to the good news on Part A, and the as your chart shows, a large aspect of the good news in Part A is the shift from hospital-based services to non-hospital-based services, including prescription drugs. Um, there's a yin and a yang on this, it seems to me. I'm not sure which is positive and which is negative, by the way. But to me, the good news is that our tools, our clinical tools to treat disease, have really expanded, especially in the prescription drug area, making it possible to reduce inpatient admissions relative to what would have been the case without these new therapies. Um, Although in the drug space, there are some pretty exciting possibilities that are being developed, including cell and gene therapies that have to be administered in the hospital. But nonetheless, overall, I think the picture is that pharmaceuticals have played an increasingly important role in treating diseases, and the net result is that is shifted services out of HI. I think I would argue that while that's good news, that's sort of artificial good news, because it really doesn't say that uh, 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 had that not happened, that HI would have, that the outlook for HI would have improved all that much. Your point that similarly, your point about the economy, absolutely. A booming economy, more people working, higher wages, and so on. Uh, that's all good news in the sense that payroll taxes go up. However, to the extent that higher wages are driven partly by inflation, that's not necessarily good news for the worker. And so I think the additional 5 years of life for the HI Trust Fund uh, is not unalloyed good news, or it is good news that needs to be thought about a lot, about what does it actually mean and what does it really tell us. And to me, it mostly tells us that we better hope the Fed gets it right, and that there seems to be, in my view, a structural shift in the way healthcare operates in this country. Uh, uh, that probably means that I would argue that interest in the HI trust funds solvency will remain, but it may be less important than more serious consideration about what that means in terms of payments to hospitals, the financial viability of especially rural hospitals or smaller hospitals to continue to provide services, the likely changes that are undoubtedly going to happen in response to continual fiscal pressure on the hospital side, and then on the Part B side, physicians in particular, there is the continuing concern well expressed by the AMA, but also well expressed in the supplemental report that your office produces every year, that physician payment, that physicians are under considerable pressure this year and in later years because of the structure of physician payment. So we have policies, uh, um, the productivity adjustment policy for everything, essentially everything outside of physician payment, and then the physician payment policy that is really putting substantial downward pressure on payment providers. And that raises the question of will there be a need for some structural reforms in those payments that can somehow maintain appropriate levels of payments without blowing up the Medicare finances, and without causing a great deal of difficulty on Capitol Hill. I'm not asking you to comment on the policy, but I am asking you to comment on sort of the trends that you see there.
Happy to comment on what I can comment on. You might also want to check the chat. There's a couple of questions that have come in, so happy to get to those as well. But uh, it is unmistakable that there has been a dramatic shift in terms of how healthcare is delivered in this country over the last several decades. So that is unmistakable, and you kind of see that throughout the presentation, both in those pie charts and the financing contributions and the like. And yes, good news for the HI program doesn't in and of itself mean it's good news overall for the Medicare program, to the extent that Part B and Part D costs are increasing. They are continuing to put greater pressure both on beneficiaries and on general government contributions. So the you can think of it as the deficit, or future taxpayers are going to feel the strains of those other programs. So that's just unmistakable. The limitations of current law, yes, that is something that is, has gotten a fair amount of attention through the reports and in some of the work that my office has done in support of that, to make sure that policymakers and the public know, here are some of the concerns, and here are the limitations, and here are what the financial effects, to the extent that some of those limitations are addressed by future legislation. One thing that we've all experienced in the healthcare space is that there are significant amount of legislative adjustments to these programs each and every year. And so some of them are more modest in terms of changing a payment rate for a particular provider in a particular year. Some of them, some of those changes are, anticipated each and every year. They're just part of the course of doing legislative business, is having to address certain aspects of the Medicare payment system. But beyond that, there are significant changes to healthcare delivery through legislation every 4, 5, 6 years. And that's one of the reasons why I like starting the presentation with, okay, here's how the Medicare dollars have changed over time, because I don't know what those next legislative changes are going to look like. I don't know where the healthcare innovation is going, that next healthcare innovation is going to come from. I think we all have our suspicions. Is it more likely to be in the drug space than in, in devices or something else? Probably, but we're certainly not going to kind of build into our projection, a pill that cures any, fill in the disease, and that could, we are going to, I'm kind of, I was comfortable and uncomfortable with the way you characterized that, what these are projections based on current law, based on what we know now. And we will know a lot more, in 1 year and 5 years than we do today. And these estimates for how spending will evolve will will certainly change. Um, doesn't diminish the usefulness of these estimates today, because this is the best that we, the trustees, can do in terms of estimating what does the program look like today based on given health spending, economic circumstances, expectations around demographics, um, and this ought to guide policymakers as they're determining how these programs should evolve. Um, Watching how things work in Washington, sometimes it's usually not with as much foresight as those that are more familiar working on 75-year projections would otherwise prefer.
Yeah. So good point. We have a question that relates to this about anti-diabetic drugs that are being used for weight reduction. But before I get to that question, let me see if I have something that I believe see if this is correct. Th that until a major category of therapies, not necessarily drug therapies, is actually covered by the Medicare program, the projections do not assume that these things are covered. Is that correct?
Yes and no. Uh, I'll hedge a little bit. So there is an expectation that some of the costs that are going to be emerging in the program are going to be newly developed drugs or technologies and the like. But there's nothing specific built in for a particular drug to treat this particular condition. And I think we've kind of had some of that discussion, as certain drugs, the ones for Alzheimer's disease is one that has gotten some attention over the past couple of years. There has not been that breakthrough there, but if and when, and we all hope that it does happen, it is likely to put significant financial pressure on the Medicare program, and so we've expect that there will be a huge amount of demand for any treatment, any effective treatment for any number of terrible diseases around, and that will change how Medicare is spending for the programs, and it might lead in well to that anti-diabetic question that's in the
Right.
chat.
So I won't read the whole question because I think we've largely answered it. But again, this is kind of more my question that the assumptions that went into the report this year were probably largely locked in very early in the year, possibly before Kim Kardashian started advertising GLP-1s as a great way to fit into a dress at the Met Gala. Is that correct?
I can honestly say that I've done no Kim Kardashian research in informing the Medicare projections. Um, just on the question of anti-diabetic drugs and the effect on the Medicare program, there is a statutory prohibition for Medicare to cover drugs for um, for weight loss, specifically for weight loss. However, to the extent that these drugs can be used for to treat diabetes or heart conditions, um, Medicare can cover those drugs. And so what we've seen is that there has been an increase in this anti-diabetic category, a lot of the drugs that are more household names. There is not the widespread ability for, for these drugs to be used for specifically for weight loss. We'll touch on like the related question of, okay, well, what is to the extent, and this is one of the reasons why the Part D program has some years of faster spending followed by some years of slower spending. That some of that faster spending is attributable to these anti-diabetic drugs. There has been clear increased use, in that category over the last several years, and we expect for the next several in the future. A perfectly reasonable question is to say, well, what effects are people having broader use of these drugs going to have for the rest of the healthcare usage? So, will there be, fewer heart-related incidents or other diabetes-related conditions being and just there's not sufficient research to kind of make those direct connections yet. And certainly, to the extent that experience emerges, they're going to, we're going to be following that. It will be updated accordingly. And there's certainly the opportunity for health savings in for these other services, for increased use in particular categories. It's just until that there's that more direct link established, they're just not going to be incorporated into the estimates.
Yeah, I mean that really sounds like a long-term research project, because of course there's always the question because you're doing long-term estimates. The question is not just the immediate effect of a particular therapy, even if it is extremely effective, not just again not just weight reduction for weight reduction purposes, even if it's extremely effective, the longer term consequences also matter, and that's in this particular category of drugs that remains definitely to be seen. Okay, we have a question about Medicare Advantage, and I'm going to read it because I'm not sure I can fully translate this question into simpler terms. But the question is, why is there a discrepancy in what Medicare Advantage insurers describe as accelerating health cost increases versus the actuaries' projections?
So this is something that has gotten a fair amount of attention, certainly within the walls of CMS, and I think outside as well. Basically, a lot of the managed care organizations that are serving the Medicare Advantage population, in particular when they were going through their first quarter results of 2024, they made a fair amount of references to increased use, in particular in the hospitalization setting, in the fourth quarter of 2023, that they were seeing upward pressure on their costs, in the latter half of 2023. Needless to say, we spent a fair amount of time looking at the Medicare experience, the Medicare fee-for-service experience, and we did not see it. So there was some gap between what Medicare Advantage organizations were observing in their experience versus what was being exhibited in the fee-for-service program. One thing that we are speculating might have something to do with this is that there are some rules that were going in place, really starting in 2024, but Medicare Advantage organization might have started this a little bit earlier, with respect to how a whole host of rules, but most notably, and one I'll mention, is just with respect to prior authorizations. And so there might have been some changes in how plans dealt with their prior authorizations, such that they saw some increase in their use as they changed some of their practices, that we obviously would not have seen in the fee-for-service program, just because there's not, the notion of a prior authorization in the Medicare fee-for-service program.
Right, and to the extent that some of those administrative changes in MA are relatively recent, it's kind of hard to capture that into the analysis as well. Let me make one more comment that is somewhat related to the trustees report, and it's just something that I think is really very important, and that has to do with the fact that for a very long time there has not been the public trustees positions have not been filled by Congress. The public trustees are, I think, a very important part of the credibility of the Medicare program, and it's something that I think has been frankly overlooked, or perhaps one might say more clearly consciously ignored by Congress. I think it's a really serious problem. The public trustees, uh, when we had public trustees, and in particular, the most recent public trustees, Bob Reischauer and Chuck Blahaus, two well-known experts on Medicare and Social Security. I can at least speak about their service to the programs in terms of bringing analytic insights and policy smarts to a very complicated set of programs and a difficult set of reports to produce every year. And I believe that their contributions were very significant, not visible to the average person, even the average person who reads these reports. But nonetheless, the idea of having an outside experts who are part of the system and who can see at a very detailed level how the reports are generated, the analysis that is done, and to provide feedback, I think has been very important over the years that was available, but that has been available for a long time. And I think that's a loss to the program, and it threatens to undermine public confidence in the fiscal responsibility that should be exercised. Every year, the trustees, and the trustees are the secretaries of labor, HHS, and the Treasury Department, and the heads of the Social Security and CMS. Every year, there is a statement that says very piously, "Oh, we need to do something." But the fact is that that statement has largely been ignored by policymakers and has generally not been aggressively addressed, regardless of who's in charge in the White House, Republican or Democrat alike. There's been a lot of fear by policymakers to pursue policies that would provide a greater fiscal assurance that these programs will continue to provide services at levels that people have grown to expect. I think it's a great concern. I think the public trustees could contribute to that substantially. And I and many others in the think tank community and the community at large, people who are most concerned about the future of Medicare and Social Security, have regularly called on Congress to move on those nominations, and we sincerely hope that that will happen sometime next year. Anyway,
I will. I'm usually very comfortable of avoiding politically sensitive topics, but in this case, I'm going to say the contributions of public trustees to the reports and to the report development process historically has been invaluable. And while we all are doing our best, all those, the four members of the ex officio members of the Board of Trustees do their best to independently represent as Board of Trustees of these programs. But the contributions of public trustees is something that is truly valuable to the process and to ultimately to the product. And so I would similarly welcome having public trustees join the process.
thank you very much, Paul. And with that, I think we have to wrap it up. It was a great discussion, Paul. A lot of issues that we didn't cover, a lot of things that we need to think about, and hope to see you again next year, maybe even sooner. Anyway, thanks to everyone for dialing in, and Paul's slides will be available at AEI's website soon. Thanks again, and Have a good day.
Okay, Ralph,